Hi folks, this is Saryam for CBNR. Today I thought we will do a sort of a video on low back pain, which is not very technical, I suppose, but rather more clinical in nature. Now, the first thing I would like to impress upon everyone who is talking about low back pain is one of the common, probably 80 to 90% of what we see in our clinic is what we call as non-specific low back pain. A lot of people have trouble with this nomenclature, but that this is the nomenclature now everybody uses because of two or three reasons. As I told you, the first reason is we all want to know what is the reason why somebody gets something. So if I say that it is not very clear, right, we are not very sure, then people are slightly offended, I suppose. But anyway, so that's what we get in our clinic. Most of them have what we call as non-specific low back pain. What we mean by specific low back pain, probably tuberculosis, which is common, so you get back pain, or tumors, or a number of conditions where you specifically know that this is the reason why you are getting a back pain, right? So today we are going to discuss about non-specific low back pain. Now, the caveat is we are not going to talk about radiculopathy because that's an entirely different issue. There is no pain, and also we are not going to talk about back pain in older adults, right? Probably beyond 65, 70, something like that. We are not going to talk about them, and also children, back pain in children we are not going to talk. Now, why? Because as we all know that evidence has to be for that particular group, right? So in this we are going to talk about only adults with back pain, right? So the first question you want to remember is all back pain or biopsychosocial. What do you mean by that is all patients with back pain will have some issues with your biology, which is muscle, bones, and things like that, and your nervous system, including that. And also the second part will be there will be some amount of psychological issues along with that, especially how you take the back pain or self-efficacy in relation to the disease. And also some social issues, how people are treating you. If they are not going to give you if you are not going to have access to treatment, how will you behave is all different from people who have access, who have money, who have access to the orthopedician or something like that. So and also a lot of people are also confused with the idea of what we mean by biopsychosocial. What do you mean by that is there are psychological, biological, and social issues, but they are not clearly delineated. So that is, these are not exactly separate. We separate it for our understanding, right? The common example I give is if you take a sambar, right, a South Indian dish. You know that if all of the ingredients together come together and it is cooked for a particular time, then only you get that that's a good smelling thing, which if you eat with your idli or dosa, it's wonderful, right? So you can't separate the ingredients, even though you can, but after it has become sambar, the whole thing together makes that aromatic soupy structure, right? So likewise, whenever you are thinking of a biopsychosocial model, you want to remember all together make up this. So, right. So this is my introduction for psychosocial. Back pain, right? Non-specific. So in the second part, so what do I do if I have back pain, right? There are a number of books, a number of what we call as the school of thought and things like that. One of the reasons I think why they have so much of school of thought and things like that is because a lot of physiotherapists, chiropractors, osteopaths, and whatnot don't study much, and they come up with nonsense to sort of a penis envy, something like that. So they come up with shit and write all sorts of things. So by definition, or it's a very, very simple disease, right? Or it's a symptom, if you will, whatever way you think it. And the first thing you want to remember if you are a clinician is it's a self-limiting condition. That is, it goes away in anywhere from 1 month to 3 months. It will go away by itself. That is, it is reversible. Right. So what does it mean as a clinician, right? If you think that the joint is hypermobile, the synergies are not proper, the joint is tight, or the muscle is short, length. So whatever you think of whether the joint is short or the joint is tight, the muscles are short, the synergies are not working properly, all these things are not causing back pain. It comes after it and it goes away by itself. So if you correct it, if you don't correct it, it doesn't matter. And in manual therapy, again, if you find out that the problem is in L2, L4, you can treat your thoracic region, the patient gets better. If you even treat your head also, they get better, and they have this fascia. Mental people, they think that the fascia gets tighter. None of this matters because it all recovers nothing, and they all seem to recover by themselves. If it is such a big problem, how will they recover by themselves? So don't worry about any of these things. And the evidence also shows in 3 directions. So if you have an acute patient, if you have any patient in your clinic, you need to do 2 or 3 things. The first thing is tell them to be active. The more they're active, the better they are. And also remember, if you are active throughout the day, you don't need an exercise. As I used to say, if you put ginger in your food, it is spice, and if you sort of crush it and drink it in the morning, then it becomes medicine. Likewise, if you are throughout the day, if you are active, you don't need to concentrate and do it as an exercise. You can be active throughout the day. The second thing is, don't tell your patient this is this and that, the joint is there, the trigger points are there, what are nonsense somebody teaches you, don't put that in your patient. This seems to be very, very important. So make them, if somebody, for example, comes with common cold, you don't tell them that, look, you don't go and make them do your spirometry and say, look, all your parameters have come down, so your hearts are gone, your lung is gone. So don't do that. It recovers by itself, right? Whatever, even if you're feeling congested in the end, you're unable to breathe and you didn't sleep, it goes away the next day. You don't. Likewise, in cold, don't make them think that this and that. Likewise, in back pain, also don't tell them all sorts of nonsense, right? Mostly paracetamol does not work, but in acute stages, maybe some NSAID might be valuable, might be not very sure. And these are the 3 important things. And slightly as if they are in probably the first week, second week, something like that, have a good exercise program. Exercise program seems to help very, very well. And a good exercise program should be tailor-made for your patient. What do you mean by that? What intensity they have to do, how much exercise they have to do, all depends upon the type of patient, how fit they are, all sorts of things. That you have to make up your mind and make them do it. Then pray, you may ask that, but in my clinic, I have seen people get better with manual therapy. Yes. And also there is another clinic where they just do IFT and they also get better. What it means is any passive technique will slowly, they will recover. Some people will not recover, right? But we will not always remember people who don't recover. So we will always think about the positive things. And also remember, because you can give manual therapy to any segment. If it is L2, we can give it to L5 or T7. Nothing changes because you're not changing the peripheral structures. You're always changing your brain. So it doesn't matter. Likewise, exercise, you can do any exercise. Most of the time, it may not matter that much, but you won't have some specific back exercise, but it doesn't matter most of the time. Have a good exercise, that is the important thing, and it should have all direction movements in all directions. That's all. What examination you want to have? The girl who worked with me put it very simply. What we do: ask your patients what they can do, tell them to do that movement, and see what's happening. Write down all the movements they are unable to do, and make them do it again and again. Probably like in a graded fashion. More than that, you hardly need any other assessment. But if you can do it, that's all right. I'm not telling you otherwise. But it doesn't mean anything. Most of your assessment should be about finding out or excluding red flags that you all know. And ask your patient to be active. That is the last part I'm going to talk about is if you are a starting therapist, right? Don't worry about trigger point, this point, fascia, all these things. They are not exclusive or exclusively working on the peripheral. Most of them are working on the brain and things like that. So understand cognitive behavioral therapy rather than moving the joint and things like that. And that is relatively very simple. The joint can be moved only in 3 directions. It's like learning to screw the bulb. There's nothing big in that. But changing a behavior patient is far more difficult. So learn those things, right? And have a good always remember there are 20% of patients who will go into a chronic stage. Those patients are difficult to manage, and they need a far more complicated multi-functional therapy. Yeah. So these are some of the musings about back pain. I'll do more in the coming weeks more about back pain. But thank you, and if you are angry with this video, come on, let's do it in the comment section and let the abuse start.